morning, everyone. I'm Tayra. Great, so I'm going to talk about our fracture on service, and I'm keeping it more to how it works at Columbia and like our experience for the past 2 years. Okay, so here's just some quick pointers about the cost of fractures. So Medicare spent about $5 billion to treat fractures since 1999. Most recipients of Medicare there's 30.2 million. Of that 30 million, 1.6 are treated for a fracture. That's an additional 7.2 million had osteoporosis, but they had not had a fracture yet. So they projected to $2,008 the cost of osteoporosis in the nation, and the Medicare population was going to be 22 billion. And they mentioned that osteoporosis was the 9th most costly major illness among the top 5 highest cost of Medicare beneficiaries. It's interesting, and I'll mention a little bit about this later, but usually when you think of like disease in older population, everyone's focused on getting regular cancer testing or getting regular like cardiovascular testing, but no one really thinks about bone fractures. I'm gonna talk a little bit about that. So in coordinator-based systems, we have the FLS, and they're kind of like a patient navigator. I'm here to facilitate care. It's the most common intervention model in literature. So when they did clinical trials, better treatment outcomes can be expected from a comprehensive program that takes responsibilities from point A to point Z, and basically from the fracture when the patient's inpatient in the hospital to initiation of osteoporosis treatment. So I'm there from like the entire get-go. Educational programs such as sending a letter to the primary care doctor, it's not enough. It's not enough, it doesn't work. The primary care doctor has so much going on. They're treating cholesterol, they're treating diabetes. It just doesn't happen, it's not realistic. So there's 3 points. So the first is identification in a fracture liaison service. So typically all men and women over 50 who have a fragility fracture are going to be assessed for osteoporosis and future fractures. The second component is investigation. So as per BMD testing guidelines and fracture risk assessment. And the third part is initiation, which is where appropriate, osteoporosis treatment will be initiated by the fracture liaison service. So here are the 4 types of models for fracture liaison services. I'm going to go from the bottom. So type D is it's just patient education. And that's usually the Own the Bone model. I don't know if many are familiar with it, but it's a program by orthopedics, and usually what they do is educate the patient, give them like a book, and that's about it. And they might send a letter to the primary care doctor. Type FLS model is just alerting the primary care doctor. Type B is ordering the DEXA and alerting the primary care doctor. And then type A, which is the model we have here at Columbia, is we have a full-time fracture liaison service coordinator. They ID the patients, order the DEXA, and link them to care and endocrinology. So it's the most comprehensive. And when you look at percentages of how many get on treatment, it's the most effective at 46%. The more effort you do, the more likely you're gonna get a patient treated. Okay, so here's a little bit about how the fracture liaison service is run here at Columbia specifically. So basically, I see all the patients who are over 50 with a bone fracture. Dr. Belzekin had mentioned before that there's like new guidelines in considering patients who have like traumatic fractures. And that's because, of course, if you're in a car accident, yes, it was most likely the car accident that did lead to the fracture, but how do we know that low bone mass was not a contributing cause as well to the traumatic car accident? Our colleagues in orthopedics, they don't agree so much, but we're still working together. So basically, you know, I meet with the patient and the family. Family is really important, especially in patients over 50, especially the elderly patients, because the more family you have, it's like more of a team to get the patient to understand and get them treated. So I give them information about the need to follow up and prevent future bone fractures. I also collect information about the patient's medical and fracture history. Our service is pretty novel, so like, you know, we're trying to get data, like, you know, we'll probably do maybe research in the future, but it's good to get some good data points on the patient. And so when I do the patient education, so I have my own, like my little spiel that I say, you know, I put the picture of the bone models. So I have bone models where.
Just put that on real quick.
Yeah.
We're getting you, but
That's just very, very low.
Okay. No problem. I don't know if I'm putting this on right. I just clip it. Great. Okay. Awesome. So I've started recently, maybe in like the last 6 months, using actual bone models that you have in like, you know, in the doctor's office of osteoporotic bone and, you know, like non-osteoporotic bone, and that's been really helpful. So I'm always coming up with new ideas and like to get patients to like understand, and when they see the osteoporotic bone, they're like, oh my God, my bones look like that. I'm like, yeah, if you broke your hip. Let's see. One of the important things I do mention is the role of an endocrinologist versus the role of an orthopedic surgeon. And for many patients, what is an endocrinologist? A lot of patients don't know what an endocrinologist, although a lot of them do know that they know what diabetes is, which is great. So I tell them, you know, like endocrinologists are doctors who specialize in hormone diseases. They take care of patients who have problems like osteoporosis, diabetes, and like thyroid issues, because everyone's heard of thyroid problems and diabetes. And I also explain to them the scope of practice for an orthopedic surgeon. So the orthopedic surgeon, they're not going to treat the osteoporosis. They're there to physically fix a broken bone but not prevent it from happening again. That's the role of an endocrinologist. I explain what is osteoporosis. A lot of patients get really scared. They're like, oh my God, I don't have this, no. And I'm like, no, it's not that bad. It's part of the aging process, it's okay. You know, it can be, you know, future fracture can be prevented, it's okay. I talk about who's at risk. I talk about the consequences of osteoporosis, so increased mortality rate. One of the things I started saying that really gets patients to think is, like, mortality rate, I guess, is not very tangible, but when you tell them that they could permanently live in a nursing home, then they kind of get worried, because no one wants to permanently live the last few years of their life in a nursing home. I also talk about the importance of having regular bone checkups, like at what year should you start thinking about getting a DEXA. You know, I compare it to getting your regular like pap smear or colonoscopy or your mammography. You know, I let them know it's all part of like routine like testing once you get to a certain age. And I also explain to them what an osteoporosis evaluation. So I explain to them what the bone density test is, the consultation with the endocrinologist, and the lab work that's gonna follow. And how often. So sometimes patients are very weary. You know, maybe they see cardiology like once a month and they're like, oh, you know, I don't want another medical regimen. I don't want to come to the hospital every month. And I let them know an endocrinology visit is not something that you have to go to like every month or every 2 weeks, like cardiology or maybe nephrology or something. Okay. So basically, you know, in our fracture liaison service, the goal is to get patients an appointment in our metabolic bone disease unit or endocrine fellows clinic. Our endocrine fellows clinic is precepted every Tuesday by 2 attendings, so the patients are getting excellent care. And we kind of time it with, we do all this after discharge. We don't do any type of bone density or labs while the patient is inpatient, because it's just an issue of who's going to be which provider is going to be responsible for the labs. So we do everything post-discharge, and depending on the fracture, it depends on how I schedule it. So if it's an upper extremity fracture and they're mobile, I'll do the follow-up in a month. If it's a hip fracture, they're probably going to go to rehab, and then I schedule the follow-up within 2 months, unless the patient's really let's go and do this, I'll come in next week. And I'm like, okay, great, even better. If the patient here at Columbia has an internist at Columbia or is already being managed by one of our endocrinologists, I alert the primary care doctor here at Columbia or the endocrinologist. Because our PCP team here they're pretty good. A lot of them do manage patients on osteoporosis, so we just kind of let them know. And we do not give them an appointment to go to the bone unit. Doesn't make sense. And if the patient's not able to come due to distance or has an insurance that is not accepted, although we basically take almost every single insurance at the private offices or the clinic, I call the primary care doctor to let them know about the patient and to ask them to refer to an endocrinologist that they know and trust that's a participating provider. So our experience has been really interesting about trying to institute this program here at Columbia. So, we're kind of making it up, seeing what works, what doesn't work. And we're not a closed system like Kaiser or Geisinger, so it makes it a little bit more challenging. All right, so just taking a closer look at our fracture liaison service here at Columbia. It's a clinical service, it's not research. So a lot of the people we work with, they think it's research, and we tell them, no, this is not research, this is clinical care. I mean, we might do a retrospective chart review in the future, looking at our data and how many patients showed up and who's on treatment, but this is not research, this is a clinical service. We do have the support of orthopedics, which is great. They're fantastic. They've been super cooperative and working with us. I've not had a negative experience yet, knock on wood. I work very closely with the nurse practitioner on the fracture service. So because all the attendings are in the OR or they're in clinic, there's a nurse practitioner that runs the orthopedic in-service, so I work very closely with her. So she'll send me referrals, the residents will send me referrals, also myself, I go on the system and I find patients because I don't rely on other people because, some patients are going to slip through the cracks. They're not going to refer to me what they don't think is osteoporosis. So I basically find out about patients through a combination of sources. Let's see. And then, like I said before, we don't do any inpatient workup for osteoporosis. Although Dr. Cyrus is thinking about kind of changing that, maybe discharging patients with vitamin D, and so she's working on that with the orthopedic team. Some of the orthopedic attendings are on board, some aren't, so that's a constant conversation that we're having right now. So to give you an idea of our demographics, so up to date, in the last 2 years, I've seen 428 patients. 67% are women, 33% are men. The age range is from 42 to 102 years old. The 102-year-old patient was one of the attendings' grandmother-in-law, so that was kind of cute. The average age is 73.6. For women, it's 75.2, and for men, it was 69.5. And that makes sense because women tend to live longer, so that's what we kind of figured. So our population is mostly a mixture of immigrants, patients from the local community, a lot of patients from the other boroughs, a lot of patients from the Bronx, Manhattan, Brooklyn, and also from the tri-state, suburban areas, a lot of patients from New York, New Jersey, Westchester County. The language that I've encountered are mostly English and Spanish, but I have seen a smaller percentage of Russian, Hebrew, Chinese, and Korean. For ethnicities, mostly Caucasian, Hispanic, and a smaller percentage of African American. And I've mentioned this before, we accept a variety of different insurances at the private offices or the endocrine fellows clinic. Let's see. So unfortunately, as much as I would love to capture everyone and link them to care, we can't. So patients that are not able to see us are permanent residents of nursing homes. And this is because they have Medicare, and the Medicare will not pay for the patients to come here and be treated. The Medicare will only pay for like the nursing home. Because they're a permanent resident, the nursing home is supposed to handle and treat and take care of the osteoporosis, not send them out. Although a lot of times this doesn't happen, and I've seen patients, who are frequent flyers from nursing homes fracture and then come back again with the other broken hip, which is really unfortunate. We also can see patients who lack decision-making capacity. They have dementia. A lot of these patients do have family, but sometimes the family is just not available to help. Maybe the daughter works full-time, and bones unfortunately are very low on the priority. So to give you an idea of the different type of fractures we see, many have had a history of a prior fracture. Half of the fractures are hip. The rest of the non-hip fractures are pelvis, lower extremity, tibia, femur, fibula, patella, ankle, upper extremities, so a lot of humerus, radius, olecranon, ulna, and very few vertebral fractures. And that's because I'm seeing the patients inpatient, and a lot of the vertebral fractures don't get admitted. And then we have quite a few amount of periprosthetic fractures. We do know that the mechanics of a periprosthetic fracture might be different because of the prosthesis, but a good chunk of these periprosthetic fractures are patients who had a hip replacement because of a hip fracture. So that's something to keep in mind. So here are some of our challenges in getting our patients to care. So a lot of our patients go to rehab, and it's not here at New York Presbyterian. It's usually off-site, and it's for extended periods. So timing can be difficult. If the patient is still in a rehab facility, we cannot see them because rehab is considered inpatient, and so you cannot have outpatient procedures while you're an inpatient. So that timing can be tricky. A proportion of our patients we saw who failed to show up to the bone unit also failed to show up to their orthopedic surgeon. So there's a lot of patients who I've spoken to, and they're like, I still have my stitches. It's not very pleasant. So, and then when we speak to orthopedics, they are the ones that told us, if we can get them to show up for us, how can we get them to show up for you? And then we have patients that they just don't want care or a new medical regimen. A lot of them are, they tell me I've made it to 80 or 85, not doing anything. I think I'm good. And also, there's a lot of patients that have multiple medical issues, and bones are very low priority. So, there's kidney failure patients on dialysis. There's patients that, have extensive cardiac disease, and they're just not interested, which is really unfortunate. So one of the biggest barriers we find is the patient's willingness to follow up medically, and we think it's because of the lack of understanding about the connections between their fractures and probable weakened bone. So like Dr. Belzikin had mentioned before, there's a disconnect between those two. So a lot of the patients are under the assumption that the orthopedic surgeon, he fixed my hip fracture, I'm fine, I'm good, I don't need any type of follow-up. So I usually have to remind the patients, unfortunately, that's not how it works. A lot of times patients forget that I spoke to them, and they always confuse orthopedics and the endocrine visit. So I have to constantly remind them, post-discharge, you're gonna have 2 appointments, one with the orthopedic surgeon and one with endocrinology. So also a good portion of patients decide not to follow up here because they came here specifically seeking a Columbia orthopedist. They're not interested in having any other follow-up care. They just want to have, Dr. So-and-so who's this great ankle specialist and never come back. Also, a lot of these patients come from hospitals in the suburban areas like Westchester County and New Jersey, and I guess the local orthopedic surgeon cannot operate on their type of fracture. So there's a lot of transfers and referrals from the nearby Tri-County area of those patients. And those patients are, they tell me, I live 45 minutes away, I live an hour, I don't want to follow up here, I just want to have my surgery and get out. And then I also have a select group of patients who tell me that, they think that vitamin D and calcium is enough, and I tell them it's great, but it's not sufficient to prevent a subsequent bone fracture. I also get patients who take vitamin D, calcium, they eat organic, they do yoga, they go to boot camp, they walk a lot, they do a lot of exercise, a lot of weight-bearing exercise, and I told them you could have all the vitamin D and calcium in the world, you could do all the yoga. If you have low bone mass and you fall, you're gonna break a bone. So some of the strategies I've used to increase follow-up for our patients is we've been adding the bone unit appointment to the discharge orders. I also speak with the orthopedic providers to encourage the patients at the post-surgery follow-up appointment to stress the importance of keeping the appointment with us. Sometimes they forget, so I email the orthopedic team maybe like the afternoon before, early morning, and then I also show up again to remind them because they're seeing like a bazillion patients, and they're not going to always remember. So when I show up with my smiling face, like they remember, and they do that, which is great, and they're really happy when they see me, which is great. I'm very grateful. I also show up at the post follow-up appointment to also personally remind the patient as well. The more reminders, the better. And I give the patient another appointment card. I say, hi, I hope you still remember me. Don't forget about the appointment. I also call the patient and family multiple times to remind them of the appointment. And lately I've been mailing another appointment card to see if that helps. I've had situations where sometimes patients cannot grasp the location of the private offices where the metabolic bone disease unit is. I've had patients go from orthopedics, then get lost to finding us, and then they just give up and go home. So for some patients, I offer to meet them at orthopedics and escort them across the street into the elevator. Or if they're coming from bone density and they're seeing one of the nephrologists, he also works with bone disease. So I have patients that will get the DEXA and then see him for the osteoporosis consultation. And, I will hold their hand and escort them. But, it works. So that's my role as a patient navigator. And multiple times work. So I've been playing around with different timings of calling. So for some patients, maybe a week before. Some patients, maybe 4 days before, and then the day before. So a lot of our fellows clinic patients, a lot of them are Latino and African American, they have a lot going on. So I'll call them, the clinic's on Tuesday, I'll call on Thursday, because if I call a week, they might forget, and then I'll call again on Monday. So that also helps. So in conclusion, we are committed to pursuing the principle of post-fracture medical care for preventing secondary fractures. Despite all the barriers and everything that we've done, we do have a lot of positive results. So 59% of patients have showed up, of the patients who decide to come to the bone unit. 27% are currently on treatment. Sometimes I get sad about the number. I'm like, 27%, it's not 100%. And Dr. Cyrus tells me that's 27% of patients who otherwise would not have been on treatment. So this is great. Let's see. Although we are finding issues with getting our patients in after we get them in. So I found out that 38% did not complete their post-consultation labs, which is scary. In the fellows clinic, the number is like 60%. I think private offices maybe like 50%. So that's been kind of scary. And unfortunately, our phlebotomy is not in the same floor as our bone unit. Or in the clinic, patients have to go to another building. So that's been a barrier for patients. So recently, I got certified in phlebotomy training. So, one-stop shopping, which is great. Training was cool. Like, I enjoyed it, but because for example, in the patient sees orthopedics, X-rays is downstairs, the lab is upstairs, so it's like all centralized. With endocrinology, it's a little bit different. So anything that we could do to help our patients get treated and prevent future bone fractures. I tell the patients in the hospital, you seem like a really nice person. I don't want to see you back here. and I mean that. And then we're also looking into getting cab fare. So Dr. Cyrus has spoke to the foundation on trying to see if we can get cab fare for the patients. And because a lot of times patients they're still in pain because of the fracture, they don't want to leave, they just don't want to do anything. It's really sad. So we're hoping maybe cab fare would be a really great positive incentive. So basically, we are changing the idea of what is the face of osteoporosis. And this is important because when I speak with the orthopedic team, their idea of osteoporosis is an 85-year-old Caucasian woman, and that's with a hip fracture, which is not true. It could be a distal radius fracture, you could be a male, you could be Hispanic, you could be African American. So we're kind of widening the idea of what is osteoporosis, and I think that's really positive. There's a lot of interdepartmental collaboration that's going on because of our FLS. So we're at a lot of the outpatient orthopedic doctors. One of the spine specialists, she loves me. She's always like sending me vertebral fractures, which is great. And then there's also orthopedic surgeons who are referring patients who do have low bone mass that haven't fractured. So we're kind of changing this idea, which is great. And in a few months, we're hiring a part-time coordinator to work with me in the outpatient side of the FLS, which is great. So we're gonna get all those non-operative, mostly like upper extremity, probably vertebral fractures that I miss because they don't get admitted. So we learned a lot in the last 2 years, and we're having to find some of the issues, and we're currently evolving and looking to seek solutions. Thanks.
Thanks, Tara.
No problem.
Questions?